Welcome to All Things Cardio-Oncology. My name is Steve Caselli. I'm the Executive Director of IC-OS. And in this podcast, you'll hear from a diverse representation from our community. We want you to be both informed and inspired by their stories and experiences, and we're so glad that you've joined us today. Well, as usual, I want to welcome my co-hosts for this podcast, Dr. Dan Lenihan and Dr. Arjun Ghosh. As always, it's wonderful to have these virtual meetups where we have the pleasure of engaging in informative and helpful conversations with others in our global community. And today is another international conversation around a truly global effort by one of our working groups. Our exercise working group recently had a major paper published in the European Heart Journal looking at research evidence, priorities, and standards in the space of exercise and cardio-oncology. And so it's a real pleasure today to have the chair and the co-chair of our exercise working group join us to talk about this paper. First, I want to welcome Fernando Rivera-Theurel, who is at the Ted Rogers Cardiotoxicity Prevention Program and the University Health Network. He's an assistant professor of medicine at the University of Toronto in Ontario, Canada, co-chair of our exercise working group. Welcome, Fernando.
Thank you so much, Stephen, and thank you for the invite to be and to have the opportunity to chat today.
And Dr. Erin Howden, who is head of the Cardiometabolic Health and Exercise Physiology Lab and co-lead of the Physical Activity Program at the Baker Heart and Diabetes Institute. She's an honorary senior research fellow in the Department of Cardiometabolic Medicine at the University of Melbourne, which means she's joining us late at night from Australia. So Erin, chair of the IC-OS working group, welcome. We're so glad you could join us at this hour.
Oh, thanks, Steve. It's great to be with you all.
Why don't we start, just tell us about this paper. Tell us kind of how this publication came about, where our listeners can find it, and probably most importantly of all, why should they read it?
Great first question. So I guess the IC-OS core working group was formed in early 2022. And as we started to bring together a really diverse international multidisciplinary team of experts in the field, we saw that there was a real opportunity for us to bring together and create a document that would potentially set the stage for this relatively new area of research and a relatively new area of patient care. Over the course of the next 2 years together, we worked on developing what we hope to be a really impactful document that is not only useful for researchers, but other stakeholders involved in cancer survivorship care. Fortunately, I think we've created a document that is going to be really useful, and we were able to publish it in the European Heart Journal. So it's open access. That was something that the group really wanted to, make it available to everyone in the community that wants to have access to what we think is the best quality evidence for the supporting the role of core in the care of cancer survivors.
Yeah. So Fernando, what would be your general take on the whole situation? Since, Erin kind of outlined the how it started. I know that you were involved at the very beginning, but it certainly developed over time. So what's your perspective on the working group, but also the paper and how it actually finally got published in such a reputable journal? That's a big challenge. So.
Thank you, Dan. Yeah, and I think it's a great effort from all the community that work along of this working group. Having this international group, I think, make it a richer because we have the perspective from different countries on how we are practicing, how we're building research, and we have the need of having more guidelines of how we need to perform research to eventually enforce the clinical practice of cardio-oncology rehab. So I think these efforts, as you mentioned, they took years, but it kind of helped us to start guiding where we need to put more efforts to increase the very good evidence that will support our clinical practice. So seeing this paper at this end is obviously a true honor. Working with people like Erin and others that were involved has been a great experience.
That's awesome. Say, Arjun, I would just be curious, this paper, one thing that it sort of highlights is the concept of cardio-oncology rehabilitation or rehab. What does that make you think of? And especially when you kind of look at what this document presents.
Yeah, I think that's a very, very interesting question, Dan, because I think in the cardiology community, we probably have a good understanding of rehabilitation when it comes to post-heart attack or for heart failure patients. And I think even from some of the oncologists, there are some exercise programs that are in place. But, how does it apply to cardio-oncology as a whole? I think is probably one of the most unique aspects of this paper, one of the most unique aspects of this working group. And I was just telling Erin actually before we started recording that we have a cardiac rehabilitation program in our unit. We do see cancer patients, and when this paper came out, this did generate some interest amongst our group for sure. So I don't know. I think maybe I'd ask it back to the experts, Erin and Fernando. What do they mean by cardio-oncology rehabilitation? Is there a definition, or is this an evolving area? I mean, over to you guys.
Thank you so much, Arjun. And I maybe can speak a little bit more about it. As you mentioned, the cardiac rehabilitation as a strategy to improve patient outcomes is demonstrated and is very widely spread across the world. But now when we involve this cardio-oncology rehabilitation term, we want to bridge the cardio-oncology care with cardiac rehabilitation. And this includes the exercise-based multimodal of care model that is used in cardiac rehab, that incorporates the parallel nutrition, the cardiovascular risk management, the education, behavioral, psychosocial support that has demonstrated to improve cardiovascular outcomes, risk, and also improve the functional capacity of patients. The point of these kind of programs that, as they're limited in time, we want to allow patients to take charge of their own health, right? So this is kind of how cardio-oncology rehab, that we know there's a need in the field, that has come together, and with this kind of evidence help us to understand more what kind of items or what kind of tools we need to incorporate in our programs.
And Erin, is that the same also from your side, or anything that's different? Does it also depend on where you are in the world in terms of what the definition is?
Yeah, that was a really interesting discussion point for the group. We all work in very different healthcare settings. So to really have universal recommendations is pretty impossible. Our sort of setting in Australia for cardiac rehab is generally a 6 to 8 week program, whereas in Canada, the programs are much longer. So that was kind of interesting. To sort of think through what is the most optimal amount of rehab that someone needs. And certainly I don't think we have that answer to that question yet. But I think it is really about these multidisciplinary models of care that are likely going to be the most effective. I think one part of the review is that they're highlighting that there is really very few studies that have adopted this multimodal model in cancer survivors, and even less in cancer survivors that we would consider those who have perhaps even developed cardiotoxicity during their treatment or have very high cardiovascular risk. So most of the studies are just kind of primary prevention. And that was something that we really wanted to kind of emphasize in the paper, is that we need to look at these higher risk groups to understand the role of exercise in those, or the role of this model in those patients as well.
Yeah,
So,
and
Arjun, I just wanted to ask. So, there's a concept that, especially when I started in medicine and particularly in cardiology, and then my main focus initially was, heart failure, advanced heart failure, and and Arjun, you're not quite as old as I am, so you may or may not have seen this firsthand, but certainly at the beginning of my training, the firsthand advice for people that were with heart failure was, bed rest for weeks, and try to manage their fluid overload or whatever was going on by bed rest. And this is a concept. And then, of course, over the years, we realized that was kind of like one of the most unintelligent things for us to recommend. And then, of course, now, there's all about, exercise and heart failure and some sort of cardiac rehab for heart failure. In the perspective of somebody in cardio-oncology, do you feel that that is the same thing that happened? So, for example, when patients are diagnosed with cancer and they're beginning some multi-drug chemotherapy, radiation, whatever uh, arduous task they have in front of them, most of the time people say, well, just rest, and with this paper and in the current dynamic, I would say that's exactly the wrong advice. Would you agree with that, Arjun?
yeah, no, thanks. I think from our local colleagues, the oncologists, they actually do have an exercise program for patients during cancer treatment. So we're not talking, of course, about survivors. And, that is something that we tap into also from the cardiac rehabilitation side. And we try and produce some kind of joint exercises between oncology and cardiology these patients. So I think I was interested to hear what Erin was saying in terms of the aspect from the survivorship and a lot of data and evidence there. But I suppose my question to Fernando and Erin would be: is there some evidence for this being done during treatment or even before treatment? And is this what we should be focusing on, building upon what Dan was saying? I mean, maybe Fernando, if I could start with you and then.
Thank you, Arjun. Yeah, and I think Erin kind of speak about some of the studies that they have performed with people receiving cancer therapies as well. And so I will let Erin give more details on that. But there is good evidence about, we know that physical activity and their level of fitness before even they start cancer therapies impact the cancer outcomes and the cardiovascular outcomes of these patients once that they complete their therapies. So, well, the problem is that there is limited information in people receiving cancer therapies that are coming from randomized controlled trials. So that's kind of the challenge. And also, some of the trials that have been performed in low risk patients, right? So we haven't seen the full impact of this intervention in the people that need it the most, in these people of high risk of toxicity, that they're receiving high dose of anthracyclines, for example, or they're receiving other type of therapies like radiotherapy that could be, obviously, that will uh, produce a lot of impact in the body and in the functional capacity of these patients. So I think that that's an area of improvement, and that's something that we found out in this paper, that we need to try to start targeting people at higher risk to try to see how we can implement it. And also, we need to understand how, no? And that's the one of the bigger questions. One of the limitations that sometimes we have is that this population is already going through many things. They have many appointments. So where are we going to deliver intervention, in a center, at home, mixed, right? So that's, we still have a lot of questions, but now there's good evidence that can help us at least understanding that we need to be more proactive to implement the strategies, nutritional strategies, exercise, risk factor management at a very early stage to prevent, right? And in the cardio-oncology rehabilitation field, we will work along the cardiologist, the oncologist, the internal medicine doctor to support the care of these patients. So, but always we need to try to reduce the burden for the patients as well. So it's not an easy population to work and even to perform research for that reason.
Erin, maybe I could just actually slightly change the question for you, because I think Fernando's kind of covered most of the points. We've been talking about, it's difficult, it's challenging for a number of reasons. So who should be providing these services? Does it come straight from oncology into the rehabilitation team? Is it via cardio-oncology? I mean, how can we, how can they be developed? What is the strategy? And you touched upon different parts of the world having different, approaches. Maybe if you could just highlight, because the group was, of course, an international working group. It'd be very interesting to hear your thoughts on that, Erin.
Yeah, it's a fascinating question. It's something we actually had a meeting about in our group today, about trying to figure out what's the most optimal pathway to get a patient after they finish treatment or during treatment into a survivorship or a rehabilitation program. And to be honest, I don't think we have the answer for that yet, at least in the settings that I'm familiar with. I think we still need to do a lot of work with oncologists and people that are providing support, so nurses, pharmacists who are supporting cancer patients through their journey, and primary care physicians or general practitioners, to make them more aware of the benefits of, or the risk in general of cardiovascular disease for cancer patients, and the need for better, as Fernando said, risk factor management, better, supportive care. Because I think at the moment, at least in the settings that I'm familiar with here in Australia, and working with my colleagues in the US and Canada, that at least that a lot of people are falling through the cracks, and they're missing out on actually getting the optimal care for just their cardiovascular risk. And so, I think there's an awareness piece that ICOS can potentially consider championing, to really increase the awareness of the importance of these elements in the care, the survivorship care of the cancer patients.
Yeah, I think the other important question I would say is, just like bringing the whole story about how we treat patients with heart failure, bringing that forward to the cardio-oncology space. So what would you say the significant milestones are in regards to exercise in cardio-oncology? So like, what things can we point to say, this is the way it was, this is the way it is, what can we anticipate in the future? So either Erin or Fernando, you can take that out, whichever one wants to take that one on, feel free to chime in.
I think I understand what you're asking, but I might can clarify if I go off on a tangent that is related to the question. But I think at the moment, as Fernando sort of highlighted, we have these good foundational evidence for the benefits of exercise training in oncology. But what we need is to generate that higher quality evidence for individuals who are undergoing cardiotoxic therapies, these higher risk groups, and in particularly even group patients where there's been acute decompensation, we see drops in ejection fraction. Can we intervene with exercise in those groups safely and restore function, or build functional capacity in those individuals? So there's a number of RCTs that are underway in different parts of the globe at the moment that are trying to look at these questions in higher risk patient populations. So hopefully, in the coming years, we'll have better evidence for the efficacy of these approaches in those people. Dan, does that kind of...
Oh yeah, no, you answered it much better than I asked it. So
okay.
But Fernando, what would you see as like an important milestone in the future? What things do you think, what could we expect to achieve, or as a collective group?
Thank you. And I think Erin pointed out that there's a lot of things coming in the pipeline, very positive to the field. But I think one of the most important things at this time is that we have identified that there's a need, and there is a big need to support these patients beyond the traditional standard of care. And I think that for me is the biggest milestone yet, because if we go back 5 to 10 years ago, there's no other options available for these patients. I mean, there were exercise programs, there were nutritional programs, but nothing as an intervention. And in traditional and cardiac rehab programs, for example, in our side, we have been doing rehab in breast cancer survivors now for almost 16 years, even before I was there. But it was in a very low risk population. Obviously, patients should not be on any type of treatment. So now we're starting to lose the fear, and with this evidence that we now have, to bring those patients that are still receiving some kind of chemotherapies or cancer therapies, patients even with metastatic disease, that we can still offer these things and go beyond just the exercise, but also be more proactive managing the risk factors. So I think the biggest milestone is the awareness as well, that now there's a boom across the globe, and centers are starting to see what others are doing, and they're just trying to involve this population in their clinical programs and also to start performing research. So I think that is a huge step for the field itself, for cardiac rehab, and more for cardio-oncology rehab. That is a very novel field.
Well, we greatly appreciate the effort you all put in organizing this paper in particular. I know it was, like Erin said at the beginning, several years in the making. There were, I think, 5 or 10 different countries involved. So that's always a challenge, and I think 15 authors. So it's a fantastic effort. And I think, as Fernando was just saying, it really sets up research for the future. Where are those points where there needs to be randomized trials and focused efforts. So we really appreciate the way you've contributed to our community in setting this out there. And we really look forward to how this is going to bear fruit in our work in this space going forward. So thank you both so much for your efforts and for being with us today to discuss what you've done.
Thanks, Steve.
Thank you, Steve.
For more information about IC-OS, you can go to ic-os.org, where you'll find more information about all of our programs, including our weekly webinars, our board certification exam, and other resources that we know you'll find helpful. Thanks for joining us today, and we hope to hear from you soon.
Free audio post-production by alphonic.com.